So I was asked to guide the discussion on the three topics which concern ALL for CAR T-cell therapy. I would say that, as you will see, the discussion is essentially for B-ALL. We will not talk about T-ALL today. And the SES has provided some suggestion that I have modified. And we could go through these slides, which concerned, as written on the screen, patient selection, what are the approved CAR T-cell products in childhood and adult ALL, and what could be possibilities for bridging and lymphodepletion chemotherapy, what are the main subject on these two items. So these slides summarize, let's say, some of the concerns which happened during the idea giving CAR T-cell to a patient with a bilineage ALL. First one is, do we have the right patient for the indication? Second, do we have a product which is approved, or do we have a clinical trial open? What kind of, after apheresis, which is not on the slides, but apheresis is of course one of the problems, what kind of bridging therapy would be undertaken, even if data about bridging therapies are really lacking in terms of prospective study. Only few retrospective studies are available at the moment. And finally, what is the best lymphodepletion therapy? So what was written on the slide when I took it was stable disease, antigen expression, burden of bone marrow disease, circulating number of blasts, and CD3 lymphocytes. I do think that some of these items are more linked to the problem of apheresis, and some are more linked to the general prognosis of the disease. So it's a combination in the slide. So I have added some things in parentheses, because I do not think that a stable disease is a condition to go to CAR T-cell. It's probably a condition after the bridge. When you have a patient progressing after the bridge, probably it's not a good candidate to CAR, but this first item is open to discussion, for example. And I would love to have your experiences.
My experience is when there is a progressive disease with a high tumor load, despite bridging therapy, the prognosis is terrible, and CAR T has little role, or at least limited, because relapse is the rule.
So I think we could agree on that. So the current guidance, Jose, is that most of us begin bridging therapy with, I would say, low-intensity chemotherapy. And when progression, then we augment the intensity of bridging. And what we have seen, and we are trying to publish this, is that the patients who go towards a low disease burden prior to CAR, but the low disease burden is obtained because of very high intensity bridge, it's kind of cosmetic, if you want, because these patients have more or less the same prognosis that the patients which come to LD at high disease burden. So low disease burden is good when it's achieved with low intensity chemo, which probably reflect the biology of the disease. But low disease burden, when it is obtained with a hammer, has really a bad prognosis, and probably must let you think about post-CAR T intervention, whatever it is. At least it is our impression after something like 150 patients treated at Robert Debré and Saint-Louis.
I fully agree with André, and either with the tisagenlecleucel in the pediatric setting, as well with the academic product non-viral that we tested mostly in the adult with Alessandro Rambaldi from Bergamo, the best results were achieved exactly with André as in both conditions only when you achieve the MRD level and with no hammer, so with no intensive chemotherapy, because even by using allogeneic source, it's important because the environment or the condition of the patient might not be supportive for the expansion of. So I fully agree on that. So, and this is open, in my opinion, the question which I raised already with respect to the future plan in the upfront. Can we consider to use, let's say, INO or even BLIN, and then in order to achieve a better MRD, not with hammer, but with more acceptable treatment, and then proceed to CAR-T?
Yeah, as a bridge, you mean?
As a bridge, so exactly, because this is, in my opinion, has many biological implications, because, of course, even practical one, because firstly, you need probably to think or to plan the apheresis up front. And then, of course, the question is whether BLIN versus INO with respect to the bridge to SCT, with the potential risk of BOD, especially in pediatric patients. But definitely, our experience is mostly by use low-intensive chemotherapy as a bridge, okay, to CAR-T.
Maybe before we focus too much the discussion on the bridge, which is very important, if we take the first block, which is patient selection, and I take your reflection on apheresis, Andrea, what would be the maximum number of circulating blasts that you would accept to go to apheresis? So you have a patient in relapse, very early relapse, for example, or second relapse after, or first relapse after transplant. What would be your number of blasts maximum that you would accept to go to apheresis? Because this is the type of question I receive every week. So I would love to have your contribution on that.
But André, I didn't know any study focused on this topic, any published study. So no, I imagine that people do their best. No formal trial directed to assess the right level of circulating blood cells in a patient that is relapsing and progressive disease. It's very difficult to understand this question. Because in real life we do our best as soon as possible. No.
I agree. But nevertheless, the question is, do you have a level? Because we could think about the problem of circulating blast in two aspects. The first one is the risk of contamination of the product, which is extremely rare, which have been described once with tisagenlecleucel by Marco Ruela in Philadelphia. But besides this theoretical risk, it never happened again in Philadelphia, and I'm not aware in any site with tisagen. The second one is to say, okay, but generally when you have blast in blood, the T cells which are exposed to this blast are not in a really good shape. So we do have this problem of when to do the apheresis when you have a relapse with circulating number of blood. I can tell you what is written in the How I Treat that Mike Pulsifer, Nirali Shah, and I think Regina Myers have written in Blood that I reviewed, which was something like between 20,000 would be kind of a maximum per microliter. So this is the kind of answer I give to the colleagues who ask me, what do I do? Can I do the apheresis with 15,000, 10,000, 1,000? So for BLIN-AJLL, we agree that it is doable, probably not with 100,000 if I be very schematic, but you are fully right, Jose. There is no study about that. And it would be very interesting to know. But as you know, any study at the moment in CAR are flawed because of the multi-parameter aspects of the final result, which is event-free survival, for example. Anita, do you have a comment on this circulating number of blasts? What would you do?
No, I'm not a real expert for the CAR T cell since we have nothing reimbursed for adults in the Netherlands.
Brexucabtagene is not reimbursed in Netherlands?
No, not.
Didn't know that.
No. So it's only because we got 3 slots for the Netherlands, and that was only in the fully north of our country, in Groningen. So that was the only place where we can treat 3 adults above 25 years of age, of course, in the Netherlands. So I know how I treat, so I can imagine that would be the most logical answer. Evidence-based, probably.
Okay. The second line, which is antigen expression, is a very difficult one to me.
Yeah.
So what is your practice about CD19 expression levels, density? How do you look for CD19 negative B-lineage LL, particularly in cases where immunotherapy with blina is in the history of the patient? I do think, for example, I can give you the example of trials. In the ZUMA-4 trial, you have, which is the trial for children. And I think it was the same in the ZUMA-3 trial for adults. You had to have less than 10% cells not expressing CD19 to be accepted for the trial, 10%. When we have 10% in a defined population, we generally are very reluctant to go to CD19 only CAR T cell because the risk of selection and clonal evolution is absolutely high. So what would be because to look for CD19 negative blast, in fact, it's not a diagnostic flow cytometry technique, it's MRD flow cytometry technique, which is much more difficult to perform.
André, I fully agree on the difficulties to identify and even more than defining then a threshold, because it really depends on the level of sensitivity that you are using. And unfortunately, especially in relapsing patients, it is not so infrequent to define the presence of CD19 negative cells. And my concern is that by pushing the use of blin frontline, still we don't know whether this landscape and this scenario is going to become even more complicated with respect to the emergence of CD19 clone, even if we consider, let's say, multiple cycle blin in the treatment frontline. So I fully agree that is unfortunately, at least in our experience, when we define the presence of a clone, a CD19 clone, a CD19 negative population, we are really skeptical to use the tisagenlecleucel because the risk of basically treating just the positive one and having the emergence of the second population is very high. And actually, I believe that in addition to the multiple mechanisms which has been explained for the antigen escape, this issue of having a CD19 negative population in your relapse population is probably more higher than we thought so far.
Fully agree. Fully agree. And what we have demonstrated in our leukemia paper was also that the fact that you observe CD19 negative relapse after CAR-T is linked to the tumoral mass. The higher the mass, the higher the probability of CD19 escape, probably because inside the big tumoral mass, there is a kind of stochastic rate of mutations which exerts a pressure of selection then by the CAR, and then you have the emergence of the population 19 negative. So there is on this slide the famous prior blinatumomab non-response. So as you may know, Regina Myers and Laura Schultz published the fact that when you have a failure after CAR-T, the fact that blina was in the history of the patient was important, especially for them who had non-response to blina, compared to the patients who had a response to blina, the prognostic of which was exactly the same that the patients not pre-exposed to blina, pointing towards a dysfunction of T cells more than a problem of antigen escape. I should say that this paper, despite including 420 patients, was not so clean in terms of the duration of the interval between blinatumomab exposure and CAR-T was extremely variable, one. Second, the blina in this American paper was essentially applied to patient blastic. So let's say the worst one for blinatumomab, and which is not the practice in Europe, where generally we debulk patients prior to use blina. So I would not say that having a non-response to blina in the history of the patient is a contraindication to use of blina of CAR-T in the following course of the patient. But it's my opinion, and if you do not agree, you are completely free to do it now.
I think we agree with you.
Okay. So these are the indication of tisagenlecleucel. Nothing special, I think, to be said. The last line is the one that I have added that we have discussed, which is look for blast subpopulation negative for CD19. The next one is the indication of brexucabtagene in adults, which I'm not an expert of. So José, you will have the floor. So do you use brexucabtagene, José, currently?
Brexucabtagene is not yet accepted in Spain.
Okay.
So in Spain, for adults, we use an academic CAR-T.
I know.
But we cannot use brexucabtagene. I have not participated in any study with brexucabtagene, so I don't have any experience with this CAR-T.
For most of us, as you know, brexucabtagene is a CD28 CAR, so it is mostly seen, despite of the paper, I will tell later. So it's mostly seen as a bridge to transplant than more standalone therapy because of the CD28. Nevertheless, in the paper, the first Lancet paper published with a very short follow-up, they were alluding to patients not transplanted and still in remission after 1 year. So, but again, we need to have the more advanced real-world data in this population to see if some patients could be, it's an interesting possibility that a very brutal CAR, even with a short exposure, let's say 2 months or 3 months, could sufficiently kill leukemic cells to prevent any relapse without any further treatment. It is a possibility, theoretically. I'm not so sure it's reality, because the prototype of this CAR was tested in the NCI by Niralisha and paper published in JCO, and all non-transplanted patients relapsed.
André, one issue, you mentioned the differences between tisagenlecleucel and brexucabtagene. But what really impressed me that by listening our colleague from UPenn, that basically were the key institution promoting the use of tisagenlecleucel and promoting all the studies, that they are using less and less tisagenlecleucel now. And one of the problems is exactly because if you don't proceed either to reinfusion or to treatment after B-cell aplasia beyond the 6 months from the infusion, the real number of patients who are still in remission, in long-term remission, in addition, of course, to Emily Whitehead, are very few.
So in our experience, Andrea, the event-free and really the event-free without use of transplant is in the range of 40% with very advanced ALL. So I agree with you, but as you know, we have looked in detail the difference between the real world and the ELIANA trial. The main difference, Andrea, is the rate of CD19 positive relapse. In the ELIANA trial, 75% of the relapse are CD19 negative. In the real world, in real world registry US, real world data in France, real world UK, it's 55 to 60% CD19 positive, which means that the CAR T which have been provided commercially do not persist as long as the other one.
Yeah,
the question is why? So we have discussed the problem of bridge. Maybe we could skip this one. Maybe nevertheless, the question that was raised by Andrea about Blina, INO, fluid, and prior to talk about lymphodepletion. In our paper, Blina and INO were associated to worse event-free and relapse-free survival. And INO comes in many studies as associated, including the recent review by Peter Bader on 250 patients relapsing after transplant brought to CAR T. And the patients with a history of INO had a worse prognosis also in this cohort. But the reason is probably because the patients who have received INO was precisely the worst one. So it's linked more to the biology of the resistance than to inotuzumab itself. So INO is more, and to me at least, and to many of us, an indicator, and I'm sure you will have opinion maybe against, but I do think that INO is a kind of indicator more than per se a risk factor. Even it's a risk factor for the transplant that you could do after CAR if you need to.
Let me just add as a last comment, one issue which I believe is very important is the lymphodepletion and the type of drug to be used, and whether in the autologous setting we can explore, or it's reasonable to explore, the reduction of the intensity, even considering what the letter in blood by the FDA on the secondary neoplasia definitely prove that these events are disproportionate, more frequent than expected to be. And they disclaim the procedure on how they did achieve the data and the concern and the warning by FDA. I believe that it's a very important issue.
Agree. Nevertheless, appeared a paper that the consortium inspired have raised with 3,500 infusion in children and no case of secondary malignancy in the T-cell lineage except one, and this one has no CAR inside. So I would say it's reassuring in pediatrics. Maybe it's more linked to adults. We will see in the future. But look at the paper published by Adam Lamble as first author and Shannon Mott as last. No case of secondary T-cell lymphoma. But in terms of flu side, I do think that the most solid data are the fact that if you have a suboptimal exposure to flu, the risk of shortening B-cell aplasia and life of CAR T cells is extremely high, and risk of relapse is also higher. So there will be a trial, if possible, between adapted flu with pharmacokinetics in real time versus standard flu that Friso Kalkun on this side of the Atlantic and Kevin Curran from MSK on the other side will run if we succeed to open it.